Hello, you can see my name, Jake Unkelman. Um, Punch it into a browser. The first slide is needed because it, basically it's required. They require a first slide here. This is a requirement from APA if they're going to get credits for anything. It basically says you've got to operate within the limits of your licensure. And that'll be an issue that comes up when we're talking about epilepsy. So we have to expect the unexpected in life. You never know when something's going to pop up, especially with epilepsy. And in the beginning of the field of neurofeedback, EEG biofeedback, before it was called even neurofeedback, you had state-based stuff like alpha and theta training. That was Camilla and Elmer and Elise Green. And that was good, good work. But the clinical work on epilepsy back then was Barry Sturman with sensory motor rhythm and Niels Spurbaumer in Tübingen, Germany, using slow cortical potentials. And they actually showed good efficacy stuff back in the 70s and have a well respected published meta-analysis in 2008 that showed 74% success in intractable cases. But it's never been adopted by general neurology, epileptology. Most of them have either never heard of it, or if they hear of it, they think of it as a 1960s hippie thing. Now, I have to apologize for all that. There were academics and military DARPA folks back in the beginning. There were clinical people and people that were into consciousness and that sort of thing, and had long hair, and I could sit on my ponytail. So pardon the reputation we gave the entire field. But at this point, we really have to expect the unexpected, because not everybody that ends up coming through the door has a label on their forehead that tells you that they have epileptiform content in the EEG, which is different than having seizures, which we'll see. Now, essentially, you can have a burst in the EEG, paroxysmal EEG event, with no seizure or with a seizure. The ones without a seizure can have a disturbance that messes up your consciousness. At the boundary of the brain and mind, there's an interface, and that gets messed up with epileptiform discharges and paroxysms. If you show an abnormal EEG paroxysm to a neurologist and ask them to treat the patient, they'll say, well, we don't treat the EEG, we treat the patient. Is the patient having seizures? If they're not having seizures, you'll probably not get them to treat the patient. They'll say, we don't treat the EEG, we treat the patient. And I respond back, who do you think made this EEG? The EEG is a direct reflection of the brain function in this patient. Now, years ago, Yuri and I were doing a lecture together in Australia. A neurologist took the VCPT task, and during the data cleanup, we saw a discharge left frontally in the EEG. He said, oh, I'm surprised anybody saw that. Like, I'm not going to see it. But it's meaningless. Well, he had a perfect performance behaviorally with only 2 omission errors, no commission errors, good reaction time, low variability. The 2 times his brain had a discharge, he had his omissions. They weren't meaningless. He just wasn't aware of them. So who do you think made it? You've got to treat the person that made it. Niedermeyer basically chastises the neurologists and psychiatrists that they have to recognize that these disorders happen, that they don't have to have an associated seizure, but you have to recognize that these mind-brain issues can end up happening with discharges. seizures are just the tip of the iceberg. You can see discharges in the scalp with the EEG sometimes we can't see them, but they're seen with the MEG. And sometimes they're just hyperexcitable. This is the epilepsy spectrum. It's not just seizures. MEG sees about 80% more spikes than we do in known epileptics. Now, let's take the ADD population, diagnosed basically by the DSM categorization, not based on EEG. This is people that have gone through the DSM route, 7 years and older, all the attentional and issues have been tested. Basically not with testing like a VCPT or anything, but just observations. The general practitioner does it based on observations and behavior. So it's a DSM category. And in that ADD, ADHD category, on the average, 25 to 30% of the kids in fairly large studies had epileptiform discharges. Classic spike and slow activity identifiable in the EEG. One study was an outlier, only 4%, because they used an EEG that was only 2 minutes long. There's a minimum time recommendation for the EEG to enhance the likelihood of seeing transients. It suggests a minimum total recording time. That's eyes open, eyes closed, task, whatever you're doing, 20 minutes to 30 minutes minimum recording time. And that gives you a little over half a chance of seeing a discharge in a known epileptic. So here, the 4% is an under-evaluation due to less time required. And the take-home lesson is pay attention to the minimum time standards, because if you take a small sample, you are going to miss some interesting events. In anxiety disorders, you don't get the 25 to 30%. It's only 11, almost 12%, but the background population is only 3%, 3 and 3.5. So this is almost a 400% increase above normal. And if you add in panic, it goes up to about 30% instead of being about 12. Actually, there are some people that would combine this with panic and show you a higher stats. I'll show you that in a little bit. In the autism spectrum, this is 72% of the total number of cases studied here had epileptiform content. The total average here is only 55%. Because of an outlier study that showed 85%, they did a 24-hour study, including sleep, over 1,000 patients, and 85% of them had epileptiform discharges, including sleep, which obviously is a time that can bring out seizure discharges in some people. So, 55, 72, this is better than even odds. I don't know about that phrase, even odds, but you know what I mean. You have a better than 50% chance of seeing a client walk through the door if they're on the spectrum. They're likely 50% or better have a seizure discharge in their EEG, and they should be treated. We're not saying they have seizures. We're suggesting that you consider treating them. Mood disorders. If you just have a mood disorder, 3%. That's the background population percentage. That's a little bit of nothing. But if you have an incongruent, which is pseudobulbar affect, it's up to 1/3 of the people. Mood disorder, like depression. In the iSpot-D study, over 3,000 patients, they only found 3.6% in the depression group. So not a gigantic percentage. But if there was a discharge in the EEG, the only antidepressant that was still effective was sertraline. Zoloft was the only one that continued to be effective on people that had epileptic discharges. Psychotic people, about a third of them have epileptiform discharges. So you can't, if you see that as a decision, if you have paroxysms and epileptiform content, you can be treated with anticonvulsants effectively, but not effectively with antipsychotics. Now, you're going to be psychotic. I mean, you're diagnosed psychosis here, hallucinations, hearing voices, command voices, things like that. And they're going to give you an antipsychotic behaviorally. The DSM is not an EEG. And if you've got discharges, you're going to be made worse by the treatment. If you look at the EEG first, you avoid the mistake of giving a person who's got epileptiform content an antipsychotic medication instead of an anticonvulsant medication. Ron Swatsina de-identified 1,000 plus, I don't know what it's up to now, well over 1,000 patients. And of that group, that they've got between 4 and 18 years old, children and adolescents, ADD, ADHD, 36% of them had epileptiform content. Anxiety disorders, this included panic, up to 39%. Autism, if you look, the lowest percentage they found was patients that had brain injuries. You'd think that would be a high probable, but again, it's the lowest percentage that they found. The highest percentage they found are people that had history of seizures, but that was only a little over half. Again, you have a little over half a chance in a clinical EEG, and that's what they found. So look at the percentages. The odds are you're likely to have these clients walk through your door. Somebody with ODD, OCD, 50% chance. If you don't look, you won't know. And if you don't know what you're looking at, you won't see. So it's important to start to know how to see epileptiform discharges. Not that you need to diagnose them, but you need to see them so that you can refer or appropriately treat or train, depending upon your licensure. So a retrospective analysis, looking back in time at non-epileptic patients who had epileptiform discharges that were treated with an anticonvulsant. No neurologist will want to treat these patients with an anticonvulsant. But of the 76 patients that were treated, 85% of them got better because they were treated with an anticonvulsant. A few of them got worse. Some of these simply had a fever or a rash, and they have to stop taking, and that's marked as a more severe clinical circumstance, so appropriately labeled as is a more severe. But again, the increased severity is truncated by stopping anticonvulsant. Some people get a rash or a fever or Stevens-Johnson syndrome, and you have to stop the anticonvulsant and do a different anticonvulsant perhaps, but you have to be careful because Stevens-Johnson syndrome is a serious side effect. What about sleep? We know if you sleep deprive people, that it increases the likelihood of a discharge by 50 to 70%. You know, everybody thinks photic stimulation at the hospital is the thing that brings out seizure activity. 4% additional yield above the resting state, eyes open, eyes closed EEG. 4%. Sleep deprivation gets you wake, sleep junction, wake, drowsy, that transitional state brings out transience, and it gives you a 50 to 70% increase in the likelihood of seeing a diagnostic discharge because of the transitional states. So, does SMR help with sleep? I mean, SMR is used for working with epilepsy, but what's it do for sleep? Well, SMR is the same exact thing as a sleep spindle. Sleep spindle is called sigma, and it's when you're asleep. Get a vertex sharp wave at CZ, when you respond to a sound when you're in stage 2 sleep. If there's a good sleep spindle, it stabilizes you and you continue to drift into deeper sleep. No good sleep spindle, at stage 2, you wake back up when you hear the sounds. The vertex sharp wave ends in spindle, the K complex. K is for knock. Click, click. You make a sound, it elicits a vertex sharp wave. That's how you document stage 2 sleep. Well, let's look at some literature. They didn't call it neurofeedback, they call it instrumental conditioning of the human sensory-motor rhythm, neurofeedback of SMR. And what's the impact on sleep and also memory, declarative learning. And what they basically found is for normal people that have some complaint of insomnia. These are college students that have some sleep issue, not severe clinical cases. They're just street insomnia. They're not clinical insomnia. 10 sessions of SMR. The control group got 10 sessions of random frequency bands being trained. There was no learning curve because there was one session here, one session there on the frequency spectrum. So they never trained SMR. And the SMR 10 sessions showed positive impact on sleep, the quality of sleep, and also enhanced declarative memory performance following sleep. So a major finding. It was replicated in Graz, Austria, and Furcheller's lab, exact procedural replication. Again, college students. But the consciousness and sleep lab in Salzburg is a major laboratory, and they don't just, they didn't just accept that as clinical. They recruited severe clinical cases, and 10 sessions didn't end up working effectively. This was replicated in the U.S., only the treatment group, not the control group, and they did 24 sessions with clinically severe cases, and that was effective in getting rid of their insomnia and sleep problem. And again, that Diego Garcia Rodriguez's PhD dissertation, Alliant University, Gewurz's student. Now, we found beta spindling is responsible for insomnia and also impulse control and a little hyperactivity. But at CZ, beta spindles were insomnia. And this was 2015 when they were looking for non-DSM research projects. And we're just looking for beta spindles. We looked for what corresponds with beta spindles regardless of the DSM category. And again, insomnia, beta spindles at CZ. CZ beta spindles are enhanced by the use of orexin. Beta spindles at CZ are the wakefulness drive, which are enhanced by the wakefulness neurochemistry of orexin. And it works quite well. Now, we've talked a little bit about neurofeedback for SMR, for epilepsy. But we also know that there's slow cortical potentials. And in the US, infraslow, infralow, depending upon what group you're working with, slow cortical potential, infraslow, infralow are all working with these super low frequencies. And they probably end up having a lot of actual cross referenceable material, but they tend to think of themselves as a bit unique. So that doesn't foster a lot of cooperation, unfortunately. But this is a 3 per second spike in wave discharge. Everybody that sees seizures knows the 3 per second spike in wave is classical absence epilepsy. The patient might have a staring spell or a blinking spell. At the most, you might see a little twitch in the thumb, but they do not see. And the little tiny mark here at the bottom is when they saw their first little inkling of something changing. And this is the 3 per second spike in wave. If you have the classic genetically inheritable recessive variant, you have a little over half a chance of outgrowing your seizures in your late teens. But not if it's 2 or 4, that varies in frequency. If it's a pure 3 per second, you have a half a chance of walking away from it. But let's look at this a little bit differently. Let's say 3 per second, but the paper speed has changed. You can see the little mark. And this is the same 6-second event. It's a short little piece. They've filtered out all the fast frequencies, and they're only looking at the infralow, slow cortical potential material. And this is the same little mark for the start of the event. But if you actually look at that mark at that point in time, a lot of these channels are going electronegative, which is up in EEG land. The rest of the world, electronegative is down. In EEG, it's up. So all of these are becoming more active. And they became more active before the beginning of the fast stuff. The channels that had the big fast stuff go more negative than the ones who stay relatively flat, which have very little activity. But the ones that go electronegative really turn on, and they all go electropositive to turn off. The 6 seconds later, now everything is turning off by going electropositive. This is why Burbaumer's group taught people to control their slow cortical potential. They would hook you up, and they would tell you to make it go up and down and up and down and up and down, like doing push-ups. Eventually, they had a little game that was like Pong. They'd have a little rocket ship that would start on one side of the screen, and it would randomly pick a spot to start in a trajectory across. And it would go put, 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 put across. And you could move the window that it could go through up and down. That was your slow cortical potential control. And it was like Pong, but instead of hitting it back, you had to let it go through the window. And they could control how fast it was going and the size of the window. So they would train you how to get faster and better at controlling the slow cortical potential. After you had good control, if you're an epileptic, they would tell you going electropositive will stop your seizures. And if you have an aura that you're about to have a seizure, go electropositive. You know how? You've done push-ups, push up, or drop down, as the case may be. Now, many years later, they move from CZ up front for ABD, and they turn it on up front instead of turning it off on the motor strip. So slow cortical potential training had over 30 years of work at CZ, specifically working on epilepsy. They have a tremendous literature. It goes into the efficacy quality literature that we have. We train our clients, and you may not have a license that, like a neurologist who's, can, in their licensure, they can treat epilepsy, or a psychiatrist who can treat a client for a psychiatric disorder. Your licensure may not allow for those, but brain optimization, we train clients to optimize their brain function regardless of DSM. And if the client has a psychiatric complaint that goes away, or if the seizures quit or something like that, like any good coach, we say, congratulations on the hard work and the learning curve. It's their success. If there's a problem, I own it. But if there's a success, none of mine. Don't blame me for your damn success. It's something I say a lot. Now, this is the last slide, because we're going to get out of the slide presentation here and actually look at some EEGs, because I think that's ultimately the important thing. You should see they have January series coming up. You should pay close attention to their contact information, so that you can get back in touch with them to tap into more of these free sessions. So I'm going to jump out of this. We're going to go into the EEGs. So we have an assortment of EEGs. We have an EEG with seizures, who's got a monozygotic twin without seizures, who's diagnosed with a learning disability, not seizures, and is not being treated for seizures. So here's the monozygotic twin who doesn't have epilepsy because she doesn't have seizures, so they're not treating her with an anticonvulsant. But she's got spikes on pretty much every page you want to stop on. It's crazy not to treat this young girl with an anticonvulsant when spikes and spike and slow discharges are happening all the way through the EEG. Her sister, who's diagnosed as an epileptic, has the same kind of discharges in the EEG. It's just that she's had seizures, and her seizure discharges involve the motor strip. But if they only had involved the sensory integration area, not the motor strip, she may never have had a seizure and may have been diagnosed with a learning disability. The discharge happens in sensory integration cortex, so it messes up her sensory integration too. But because she did have a seizure, she's diagnosed and they treat her for a monozygotic twin, who's her exact phenotypic, doppelganger, unless you acquire a problem with a whack in the head or an overdose or some stupid thing in life. You've got the same hand dealt as your monozygotic twin, the same exact phenotypes, same genotype, same phenotype. If you have the same phenotype, you get the same treatment. Doesn't matter what your damn DSM says. So these two would have gotten the same treatment, and they should have gotten the same treatment based on the EEG. Not a bad thing to look at. It's a good way to lead off. What do you think we have here? This is not an exact 3 per second spike in wave, is it? It's kind of 1, 2, 3, but it stretches out. There's only a couple here. Remember when I said if they stay exactly 3 per second, you have a half a chance of walking away? Well, this doesn't stay. And you can see the little spike that started it out. Where did it start? Yeah, a little central, but plenty of temporal. But this is not just spike and wave. This, I think, also ends up having some polyspike. We'll see. Again, a really big spike, and then spike and slow. Didn't build itself out into a full discharge, but this has got a spike in it as well. There we go. We have there's some of these that end up having kind of a spike instead of a spike and just slow. But spike and slow EEGs are absence-related epilepsy. Look at the size. Got a pretty good size spike here. So the size of that spike, if I slide the EEG over next to the blue cell, that blue cell is 2,000 microvolts. Now, if you're at perception, you're doing a BCP task and you make an animal or a plant or you choose a checkerboard or something, a cognitive percept, you might get a 10 microvolt. It's a really good ERP. So this little perception is being shunted around to be interpreted and understood. You perceive it, then you process it, then you understand it, and then you can differentiate it. I mean, all these processes are going, but this little 10 microvolt little boat is hit by a 2,000 microvolt tsunami up front. And that tsunami wipes out the ability to track anything. So you end up with an absent spell, literally a piece snipped out of your arm. You can't, if you tell little Johnny, tell me, can you hear me, little Johnny? Until the end of this, you don't get any little Johnny answering back. There's no little perceptions of, hey, little Johnny going on. They're being hit by a 2,000 microvolt gigantic tsunami. Whispering at a rock concert. You're overwhelmed. So that's a 3 per second spike and fairly classic spike in wave. But let's look at something a little bit more subtle. This is actually a Tourette case. And this is a person who had tics and vocalizations. And their vocalizations were wordy. You don't have to demonstrate limbic speech here. I'm sure you can all come up with a few examples of limbic speech on your own. But what we're doing is going through the raw waveforms of the EEG. And just keep your eye open for a spike. And you turn up the sensitivity one more notch. This is about what we've got. And it's pretty easy to spot spikes when they happen. Oh, look at this spike going by in the middle of the page. Now, you might say, oh, well, how do you know that's not just a bad electrode or something? Well, field and phase. That's the same spike that hits here and there and here and there. And if you look really, really closely, C4, which is motor, is just a moment before it. And it's out of phase between the motor strip and the temporal area. So the motor tick and the vocalization. Now, the spike was identified. The patient basically, in a case like this, was referred from a psychiatrist. It had ADD and a Tourette tic and a vocalization. And we saw the spike and suggested that they actually put the kid on an empirical trial on an anticonvulsant. And this was Lamictal, lamotrigine. And the tics went away, but the family got pretty concerned that our anticonvulsant stopped the tics. And so they went to UC San Francisco Med Center and neurology department, and they went in and said, little Johnny had tics, and they went away on lamotrigine. Does he have epilepsy? And they said, well, you're on a very, very low dose of lamotrigine. We don't tell people to put a high dose. Very small to moderate dose is all it takes. We're not trying to stop convulsions. So you're on a very, very low dose, and they did their own EEG. They did not see any. The absence of evidence isn't evidence of absence, I might remind you. If you don't see when it doesn't mean it didn't happen, you just missed it. Remember the Martijn Arns paper with 2-minute EEGs? I was a co-author. There weren't any spikes because it was 2 minutes and there were 18 minutes missing. So you couldn't see any if there were there. So the neurologist says, well, there's no spikes. You're on too low a dose to be effective anyway, so you don't need to be on it. Well, it wasn't his prescription. And he changed. The tics came back. Notice the spikes. This one's thrown out because it's too big. Just automatic de-artifact throughout an actual clinical spike. Now, there's enough going on that I'm not going to miss that. There's plenty of spike discharges piling up here. So the family now takes the kid off the Lamictal. and the tics come back. Now they are totally freaked out, and they want to talk to me because I'm the one who did the report that told them to try Lamictal in the first place. So I say, okay, get the neurologist and his EEG to meet me with our EEG at the same time in the same place on the internet, and we can have a discussion about this, which they arranged. Not easy. I was, multiple people schedule, not easy. But eventually all clicked, the stars aligned, and the doctor showed his EEG. We agreed there's no spike in it. Again, absence of evidence isn't evidence of absence has been told to me so many times, I had to say it back to the neurologist. He had to agree. Of course, they use that phrase all the time. Had to agree. It's their phrase. So, what else do we say? The presence of a finding is a confirmation of the finding, and we looked at the EEG we had, and we saw this very same kind of spike. And he had to agree, yes, it's a spike, and the empirical evidence is that when put on a low dose of Lamictal, the tics went away, and removing the anticonvulsant at low dose, the tics came back. So a low dose anticonvulsant was in fact effective. And this is a patient that would probably not have gotten any medication because Tourette tics don't get EEG recordings in a hospital. They record for epilepsy, not necessarily everything. And they record for encephalopathies. It's one of the reasons that their big AI push to understand psychiatry with EEG has not really worked very well. If you go to the hospitals and universities that do EEG, classically, all of the ones they have are epilepsy and encephalopathies. They don't have the autism and the depression and the ADD and all of the panoply of other things. So AI is going to take a while. Anyway, we can see the spike. When you see spikes like this can be referred to friendly neurologists that work in our field. If you don't know a friendly neurologist who works in our field, ask Kelly. He has a handful of them. He used to work with Rusty Turner, Robert Turner, network neurology, epileptologist, child neurologist. Excellent opportunity to refer to Rusty. You could refer to Diana Martinez, MD neurologist on the East Coast, Boston Neurodynamics. But there are good options to refer to people in the field that are open to the referral from somebody that works in neurofeedback, not neuroscience in the hospital. Sometimes referring to a neurologist, if you're not a medical practitioner, becomes a little awkward. I had a client who referred an epileptiform discharge to a neurologist in his community, and the response back is, "Why are you doing EEGs? You shouldn't be doing EEGs." Well, I'm not going to look at this EEG. You shouldn't be doing this EEG. And ended up challenging his license. Now, he was a neuropsychologist, and he did the recording, but the report was signed by people with better medical credentials than the local neurologist. So, he was fine. In fact, after a litigation from his licensing board, they had to pay him back his lawyer fee. And after 3 years of trying to get him thrown off his license. So, they paid him back, and the person who was the complaining person on the licensing board got fired from the licensing board because it cost him so damn much. So it's slowly opening up out there. You can see epileptiform discharges right in front of you. Make a good referral. They happen again and again in this case, and it's not the only case. Now, we have about 45 minutes or 15 minutes. I've gotten about 45 minutes done, and I would like to open this up for questions. And if that's possible, if the moderator can pop this open.
Yes, of course. Hi, everyone. So we are moving on to the Q&A segment of our webinar. Our first question is by Silvana. She says, "Hi, Jay. Greeting from Macedonia. Which medication do you recommend the most in children with autism with discharges? I have the same problem with neurologists that do not prescribe the medication to children with NDD and discharges."
Yeah. Obviously, it's good to hear from you. Say hello to Jordan, Pop Jordanov, and his wife, fabulous people at the Macedonian Academy of Arts and Science. If people want to go online and take a look at the facility, even it's a spectacular facility. So thanks for the question. It depends upon what kind of discharge. In the temporal area, Keppra is a very good one, but Lamictal is also a very easy one to try. Lamictal doesn't, other than the startup on the Stop Possible Stephen Johnson with a rash or a fever, it's usually extremely well tolerated at low to moderate dose, and that's usually what we're recommending. Again, we're trying to stabilize the EEG. We're not trying to stop some out of control epilepsy case. Although that's what I've specialized in for the last few years is intractable epilepsy. And we've got very good results on that, including online. If you punch in for Maggie, she's seizure-free still 5-6 years maybe now. She was about 8 years old and had intractable epilepsy, and she was on 3 anticonvulsants, and Onfi was costing $1,000 a month for the copay. And 72 training sessions later, she's seizure-free, medication-free, took a long time. But once you don't have seizures and your EEG is clear, the epileptologist isn't going to keep you on meds. They're going to pull meds back one at a time, carefully, and that's what was done. And she became medication-free and seizure. Yeah, thank you for posting Maggie's story in the chat. That's a great video, short clip. Just this last week, you never know who's going to see something somewhere. In Australia, a mother somehow saw Maggie's story, and her kid needed to have an EEG done. They somehow found their way to me, and I got a hold of John Haig in Australia, who was in the location where they were. You could get the EEG recorded and could help with the neurofeedback and the severe intractable epileptics. We worked with an 8-year-old in Israel who has Dravet's, which is an intractable epilepsy. It's a very severe circumstance. Your life expectancy is basically vegetative care. I mean, there's no real likelihood of getting better, really. Dravet's is, you started to develop okay. About 2 years old, you started to have uncontrolled seizures, hundreds a day. You lose your speech, you lose your motor control. She couldn't tie her shoes, she couldn't speak. 8 years old. 42 training sessions, the fastest learning curve I've ever seen in an epileptic. And we usually tell people it's 100 sessions or more. 42 for her. Riding a bicycle, speaking fluently, with a life trajectory of something other than a basket case with custodial care. Again and again. And we just finished publishing, and I think this is the case Isabella. And Isabella is graduated already at this point. And she was a young girl, about about 10, 11 years old. She had some ADD treated in the U.S. Her EEG was sent to my company. We sent the report back, including the comment that there was epileptiform content in the left temporal lobe. And the therapist didn't show them the report, which told of the spikes. They just did the training, and the family moved over to Barcelona. And in Barcelona, as a young teen, she started to have seizures and became an intractable epileptic with hundreds of seizures a day. Now, when she was young, she had strabismus and enjoyed tennis. And her whole motivation in life with her intractable epilepsy, with hundreds of seizures a day, was to play tennis again. So, they went through traditional medical treatment. 3 anticonvulsants is as many as they want you to be on. They couldn't find 3 that would control her. They basically said, we need to cut your right temporal lobe out to stop your seizures because that's where they're coming from. Well, the family decided they wanted to do neurofeedback before they tried brain surgery. The surgeon and the neurologist said, if you don't do the surgery, you're going to kill your daughter. That's the exact words. Where do you learn bedside manner like that? How awful. So, they basically went ahead and did neurofeedback, hundreds of neurofeedback sessions. 350 sessions later, she's seizure-free and medication-free. She is now graduated. She's 7 to 8 years seizure-free now. She graduated from Baylor University on a full tennis scholarship as an endowed athlete's scholarship, a full ride as a tennis player. She's got 1 year left of eligibility. She's in grad school there, getting her master's degree in communications, and she wants to use the publication of her case story as part of her outreach for neurofeedback for intractable epilepsy, which is essentially in need of a spokesperson. And I think she's really quite an impressive spokesperson. Anyway, there's probably other questions.
Yes. The second question from a different participant said, hello, Jay, what would you consider as someone who is sleep deprived? Is that someone who does not sleep for a full 8 hours for a specific amount of time, or is that more based on the client's report of feeling groggy, brain fog? Would SMR be helpful for any amount of sleep deprivation?
In fact, if you have sleep problems, SMR is generally a good idea. There are some kinds of sleep onset problems that aren't just beta spindles at CZ, and SMR at CZ may not work. If you have rumination at the frontal midline, you have to work up front. So you have to look at the EEG. It's not just DSM cluster based, but SMR at CZ works really well if you have beta spindles. I think I lost the first part of that question.
Oh, yes. It was just defining sleep deprivation, whether it's just the full 8 hours.
Yeah. In kids, you want to assign one parent for the first half of the night, the other parent for another half of the night, because if you're an adult, missing a whole night of sleep is really hellacious. And it's not that bad for kids, apparently. The kids seem to make it through the night, but it does set them up for drowsy transitional states being recorded, and that brings out the likelihood of the discharge. So it's missing a night's sleep, not just feeling drowsier than usual, not just having had a bad night's. If you're going to sleep deprive somebody specifically, you probably already have done a routine EEG, found nothing specific, and you still have a strong suspicion. At that point, sleep deprivation in a repeat is a perfectly appropriate procedure. And you don't necessarily do quantitative EEG, eyes open, eyes closed, compared to a database because the person's sleep deprived. This is for the EEG, not the QEEG. Epilepsy is best seen in the EEG. QEEG, you can quantitatively analyze it, spike dipole analysis. There's all sorts of kinds of quantitative analysis you can do, but just general brain mapping of the full EEG, spikes will average out more than average up. So there are specific techniques to end up seeing.
Thank you. A different question by Silvana was, what was the dosage for lamotrigine in boys?
Lamotrigine, and that all depends upon age and weight. There, actually, there's dose per weight information in the physician deck reference, a PDR for each of the medications. You can have the ability to dig deep in each and every one of the medications, and they'll give a dose by body weight. And there's also advice as to what ages are appropriate. And for a lot of anticonvulsants, below age 6 or 7, it's hard to find something that they find appropriate. So if you work with very young kids and you see epileptiform content, it's best to end up working with an epileptologist as a specialist if you can find one. And again, here in the U.S., Rusty is an epileptologist, but there's others.
Okay. The next comment and question is by Carmen. She said, I have been told by a superior to not record any more than 10 minutes eyes open and 10 minutes eyes closed because it's a waste of time. Thank you for validating me wanting more data, as well as how
10 minutes eyes open, 10 minutes eyes closed gets the bare minimum. Mr. Scrooge would be happy to see 20 minutes and not a minute more. But getting 30 minutes gives you a big percent additional likelihood. And the minimum standard is 20 to 30, not 20 and not a second more. So you should feel validated, and you might want to point to the American EEG standards, the ASET, ASET, American Society of Electroneurodiagnostic Technologists, have the standards that were set between the neurologists and the technologists back in the 1950s. And, seizure detection hasn't changed any since then as far as the incidence in a resting state EEG.
Thank you. And her question was, how do techs get paid more than 1 hour because it takes more than 1 hour to discover these things? Is there a way to bill for this time?
I'm not the best one for billing. I've usually operated in a back lab on analysis, not as a billing one at a time for the work. There's billing codes for the EEG. There's billing codes to get paid more for the analysis. Digital analysis of the EEG as a technical code, just like the technical code to the EEG recording. And if you're doing the QEEG processing in any sort of a way, those two are technical, and the tech should be being paid those. The professional component goes to the doctors, the technical component goes to the techs and the people that operate the tech equipment. Now, quite often the doctor owns the tech equipment and will just pay you your fee for your time. Again, there's the billing for the EEG. There's an interpretation of the EEG. There's the digital analysis of the EEG. They don't call it QEEG. Digital analysis of the EEG. And it can't be just pushing a button and getting a printout. There has to be some time spent analyzing something. They specifically say the push button report is not billable as an option. You've got to process things, spend some time, find some spikes, do the dipole analysis, plot something. They don't want to have a push button printout as the digital analysis, but that's a billable. And then the interpretation of that is the fourth billable piece of the EEG and QEEG. So it's see if you can squeeze the other technical component out of the people that are you're working with. Pay rates, by the way, vary wildly across different states, even within states. Big city, small hospital, rural. I mean, a fairly dramatic difference. If you're a tech and you own your own equipment and you're doing mobile, you set your fee. They're paying for the tech and the equipment and the recording. the analysis will be by the doctor who ends up signing the report. But as a tech owning your own equipment, you basically set your technical fee, whatever you want. They have to pay for your travel and all that. So set your fee.
Right, for the convenience. Our last question by John is, hi Jay, speaking of some of the cases you were referring to, are there any age-related issues, age of onset, length of time having activity that impacts the effectiveness of neurofeedback?
Well, great question. It'd be wonderful to have the data to answer it. I don't know of an early enough age that you can't have some impact. It becomes more and more difficult to provide feedback in some meaningful way. Young infants may respond to tactile feedback even before they're able to respond by sitting and watching a cartoon that they like to see. But it's pretty hard to find a 2-year-old or a 3-year-old who won't sit in front of a screen watching a common, I don't know, what the cartoons are nowadays. I'm so old. I don't know what the kids watch as little kid puppy stuff on TV or whatever I've seen little kids watching. So sitting in front of that, and the screen can dim and gray out or get smaller or less hard, depending upon the AG. That's direct feedback. You don't have to know what you're doing in feedback. In fact, knowing what you're doing is exactly wrong. Trying hard to relax, try that sometime, but there's no instruction for neurofeedback. If I could tell you how to do it, talk therapy would be what we were doing. I get better outcomes with neurofeedback. So, it's age as soon as you can provide feedback. And depending upon how severe it is, you may want to intervene early. As chaos theory might predict, early intervention leads to later life dramatic outcomes. And even intervening later ends up helping. But getting an early start on something will allow the brain to end up developing with an intact neural set. And if you're going to stop discharges in the EEG that aren't symptomatic, please do it before puberty, because puberty lights them up like nobody's business. And real common age of onset of seizure, puberty.
Thank you so much, Mr. J. Let's see. Carmen had one last comment. Thank you, Jay. Your response was very helpful. And thanks to you, John, it's hard to watch my uncle and aunt struggle. English is their second language, and now they decided they will pay for neurofeedback out of pocket. Now finding a provider to take the case is the next step.
It's always difficult. And, I'm retired from writing reports, but it's extremely hard not to respond when a family reaches out saying, my son, my daughter, my relative, my friend has intractable epilepsy, and the doctors can't help them any further. Is there something we might do? And I know there is. How can you say no? How can you deny service? So I still end up doing some consulting with people that are going to be doing the clinical work to end up coming up with the appropriate training sites and tuning and essentially what people call protocol, which is kind of a dirty word in my book. It sounds like, oh, you have this, you take that. It's not that cut and dry. The DSM doesn't work. So there's no predictive validity. The EEG, however, does a pretty good job predicting what you end up needing if you actually look.
That makes a lot of sense. Thank you so much for everyone for attending today's webinar. Thank you specifically, Jay, for your valuable time and excellent presentation and allowing us to see all those EEGs. Thank you so much, Jay. I appreciate all your time once again. Have a good evening, everyone.
Bye-bye, everybody.